There we go.
Okay. So, hello everyone. My name is Abdulrahman Alfraih. I'm a internal medicine senior registrar in Kuwait, and I'm pursuing my cardiology fellowship starting in July. So, based on my understanding, you're all medical students in the UK and a few other places. So I guess this session is probably more for like the basics of ECG and different types of ECGs and just a systematic way of interpreting everything. Okay, so the most important thing I think is to make sure that we know how to place our leads, because a lot of medical students that come to us when I tell them to go do an ECG, they say, oh well, the nurse, we just asked the nurse to do it. And so I think it's important for every doctor to know how to properly place an ECG. And there's two components of placing ECGs, and from these two components we get three sort of variables and three things that we measure. So first of all, looking at the chest leads, there's 6 chest leads that we use for our basic ECG. V1 goes in the right lower sternal border, so that's the 4th intercostal space, just right to the sternum. V2 goes to on the left lower sternal border. V4 goes at the 5th intercostal space and mid-clavicular line, which is your apex beat. And V3 goes between V2 and V4. And then V6 goes at the 5th intercostal space, mid-axillary line. And then you place V5 between V4 and V6. So there's really only 4 locations that you need to learn. And the other 2 you can just put in between. So the limb leads, they're a little more complicated. And there's 3 leads that you put on the patient. So there's the right arm, the left arm, and the left leg. And from these, you get your regular limb leads, which are leads 1, 2, and 3, and I'll explain exactly what they are. And you also get the augmented limb leads, AVR, AVL, and AVF. So leads 1, 2, and 3, what the ECG machine does is that it reads the electrical activity from 2 different sites. So let's say looking at the leftmost picture, you're looking at lead 1. And so what the ECG machine does is that it looks at the electrical activity in the left arm, looks at the electrical activity in the right arm, and then it subtracts what it reads, and it gives you lead 1. So when you look at lead 1, it's like peering through a camera on the left arm, looking towards the right arm. And so any electrical impulse that comes towards you, that's what lead 1. So that's electrical impulse in that sort of plane. And you can apply the same thing to leads 2 and lead 3. So lead 2 is what the machine reads from the leg and what it reads from the right arm, and it subtracts both, and you get this vector lead 2. And the same thing for lead 3 as well. Lead 3. Now, when it comes to the augmented leads, some people may be a little more confused about augmented limb leads. So we'll take them one by one. So looking at AVL, it's an average of 2 sort of vectors. So it takes impulses from the right arm to the left arm, and then it also takes impulses from the left leg to the left arm. And what it does, it makes this calculation where it adds these 2 vectors together. And the average of that gives you AVL. So you're starting to see that every sort of lead has a certain directionality to it. And that will help us interpret where the electricity in the heart is is going towards or going away from. So same thing with AVR. AVR is the ECG machine interpreting things from the right arm. So whatever is receiving from the left and whatever it receives from the leg. And by placing these two together, you get an average. And so that's AVR itself. And the same thing applies to AVF. It's basically lead 2, lead 3. And putting these two together, we get AVF. So whenever you're looking at a lead itself, it gives you clues on the direction that electricity moves towards. So if we're looking at lead 1, we're looking through this plane in your body. This plane going towards the left arm. So if there's any positive deflection in the QRS, that means that the electricity is coming towards you. So it's coming towards the left arm. If there's a negative deflection in the QRS, it's moving away from you. So it's moving in the opposite direction. So negative is always opposite direction. And equivocal QRSs, they're usually because electricity is moving perpendicular to the line of axis. So it's either 90 degrees up or 90 degrees down. So anything within the blue semicircle, that's angling towards the plane that you're receiving the electrical impulse in. So we have 3 limb leads. We have 3 augmented limb leads. And this is basically what we were discussing before. But if we just reorganize these arrows into something more organized and something that we can understand better, we get this. And I think everyone's seen this in their books and like become very confused. By using this, we can see that different leads have different directions. So if something's positive in lead 1, it's probably negative in AVR. Now, when we talk about access, a lot of people have different ways of learning how they look at a normal axis or axis deviation on the ECG. And a lot of people have thumbs, away is left and towards is right. But I think if you understand the concept of it, then you can expand that knowledge and you can apply it to all different leads on the ECG. So we're talking about leads 1 and lead 2, and that's what really compromises the normal axis. So the light blue semicircle is lead 1. So any electrical activity moving in this direction will give me a positive QRS. Any electrical activity moving in this direction will give me a negative QRS. The same thing applies with lead 2. So anything in the direction of the bigger, darker circle will give me a positive in lead 2. And if you overlap these two together, you'll get this angle, which is the plus 90 and the minus 30. So that's our interpretation of a normal axis. If lead 1 is positive and lead 2 is positive, then you'll get the normal axis. Now, with left axis deviation, we apply the same fundamentals, looking lead 1 and lead 2. So lead 2 will be positive. Lead 2 will be negative because it's outside that angle. That lead 2 will give you a positive result, so it'll be negative. But lead 1, since it's still in the positive range, it will be positive. So that's left axis deviation. And this is just an ECG example of a left axis deviation. You can see a positive lead 1 and a negative lead 2. And a lot of doctors and medical students say that since the QRS complexes are leaving each other, then it's a left axis deviation. That's a nice way to remember it, but also don't forget the actual physics that's involved in it. Right axis deviation, about the same concept. A positive lead 2, because it's in the larger angle of lead 2, but a negative lead 1. And that gives you a right axis deviation. And that's explained here as well. So you've got a negative lead 1 and a positive lead 2. And because they're coming together, so they're right, or they're shaking hands. Now, this is a normal ECG. So when we apply the issues of axis, we can see that lead 1 is positive, lead 2 is positive. And another good clue for looking at people with normal ECG is that the QRS complexes in the chest, the R wave will gradually increase, and reach its peak in V6. So V1 to V6, you get that positive QRS because you're moving towards the left ventricle. And the left ventricle is the stronger part of the heart. And so you're receiving electricity when you get to V5, V6. So it's positive in V5, V6 because you're receiving the electricity. Now this is an abnormal ECG, okay? Abnormal in a couple of ways. So we see that there's a negative lead 1 and a negative lead 2. But also, what we see is that V5 and V6 are positive. So V5 and V6, they're receiving the electricity. So it's all towards the heart, but V1, and lead 1, it's negative. So we're getting conflicting information here. A good clue is that the AVR is positive. If you see a positive AVR in your ECGs, usually it means that there's some sort of lead reversal. So whoever did the ECG probably put the AVR on the right or on the left. So there's some kind of confusion with the way that they did it. So if you have a positive AVR, that means the electricity is going towards AVR. It's going all the way at a different angle from our normal axis. It's called extreme axis deviation. This has some the electricity is not going towards the left side. It's going more towards the right. And actually, this is a case of dextrocardia. So that's an interesting ECG for you.
Rahman, sorry to interrupt. There's
yes.
someone in the waiting room, I think, or a few people.
I think I added them.
Oh, okay,
already.
Perfect. Okay.
I hope so.
Yeah.
All right. Yeah. So when interpreting an ECG, always use a system. I still to this day use the same system that the rhythm, rate, the axis, look at the PR segment, the QRS duration, and any
I think you're cutting off.
irregular.
I think there's some network issues.
Are there network issues? Sorry. Let me just check.
Yeah. Yeah, I think you cut off when you were explaining the system.
Okay, 1 second. Okay, can you hear me now?
Yeah, that's good.
Okay. So there's when you're looking at the rhythm, regularly irregular means sinus rhythm, which means that the P wave is followed by a QRS, and every QRS is preceded by a P wave. Regularly irregular rhythms are usually AV blocks, and irregularly irregular rhythms are atrial fibrillation. So if a doctor gives an ECG and you say that it's irregularly irregular, that means you want to tell them that this case is an atrial fibrillation case. So when you're calculating rate, there's 2 ways to do it. The rhythm strip in an ECG, it's usually 10 seconds long. So by default, if you count the number of QRS complexes that are on the ECG, you multiply it by 6, you'll get the rate. But to be honest, I mean, that's very good if you have an irregular pulse. So if you have an an atrial fibrillation with a varying degree of rate throughout the rhythm strip, then that's fine. But I think what's more smooth and much more professional is if it's a regular rate, you look at the RR interval, calculate the number of big squares, and then you do 300 divided by the RR interval. And I guess with time, you'll know that 2 squares is 150 beats, 3 squares 100, 75, 60, and 50. So with good practice, you'll just remember the numbers and you can pick up the rate in a second without counting all the QRSs on the ECG. So we'll talk about first degree heart block, and I'll show you some ECGs after that. A normal PR interval is between 3 to 5 boxes, or between 0.1 to 0.2 seconds. And it's important to say that it's the beginning of the P to the beginning of the QRS. And a lot of times, first degree heart block is usually a benign condition. It's a normal variant. You definitely see it in elite athletes, but it may be a sign of pathology, especially in ischemic patients who had damage to their AV nodes. And drugs can cause them as well, such as beta blockers, calcium channel blockers, and amiodarone. So this is the first example of a heart block. So I'm just going to give you a moment to take a look at it. Ahmed, are my ECGs clear?
Yeah, they're good quality.
Okay. Yeah. So same thing. We look at the rate. So it's a regular rate, normal rhythm. So that's a QRS, that's a T, that's a P. And see that prolonged PR interval. It's up to 12 boxes. So that's almost half a second delay between the P and the QRS. So this is a first degree heart block. Now, I'm going to move on. I'm going to give you another type of heart block. And we'll interpret this together, I guess. Can you still hear me, Ahmed?
Yeah.
Okay. So looking at the ECG, you've got a normal. So looking at the rate, I would say that this is a regularly irregular rate because, okay, some QRSs are preceded by P waves, but not all P waves are succeeded by a QRS. So we see the PR interval here, maybe a little longer, and then there's that drop right there. Okay, so normal PR interval, it's getting longer, and then that little P, which is hidden in the T wave, causes a drop. And this is Mobitz 1, it's the Wenckebach block. So this is the third example of a heart block. And same thing, we say this is a regularly irregular heart rate. QRSs are preceded by a P wave, but not all P waves are followed by QRSs. And if we look closer at the PR interval, we see that it's not prolonging, it's fixed, okay, until it drops here. So this is these are second degree heart blocks. So there's a Mobitz 1, which is a gradual prolongation of the PR segment. And the pathology, it's usually involving the AV node. Mobitz type 2, there's no change in the PR length, but it's followed by a QRS drop. And this is usually because of the pathology to the His-Purkinje system. Mobitz 1 is usually more benign, but Mobitz 2, if you have a Mobitz 2 patient, then they're much more prone to developing complete heart blocks, asystole, fibrillation, and sudden death. So it's very important to differentiate between the two. But there are some situations where you can't. So in this example, We're looking at a case which is a regularly irregular heart rate. We see some P waves followed by QRS. That's a T wave, and then another P with a drop. So we can see that for every 2 P waves, we have 1 QRS. And so this is a type 2 heart block, but this is a 2-to-1 heart block. 2 P waves, 1 QRS. 2 P waves, and only 1 QRS. So in this situation, you can't comment on whether the PR is prolonging throughout the ECG, and it's always important to treat it as if it's a more serious condition. So you always consider this to be Mobitz 2, more serious, and you involve the relevant services. So you call the cardiologist, you involve the electrophysiologist, and most likely once this patient stays in hospital and you monitor him, with time, with the monitor strip, you'll get more accurate runs of his arrhythmia, and you can probably decide whether it's a Mobitz 1 or 2. This is the next example. So this is also a regularly irregular ECG. P waves are regular, but also QRSs are regular. So this is a complete heart block. You can see that the QRSs are regular and the P waves are regular. So RR intervals are fixed, PP intervals are fixed, and there's atrioventricular dissociation. So we assume that the P wave isn't transmitting its impulse to the AV node, and the QRS is completely dissociated. And the causes are inferior MI, and AV node blocking agents such as beta blockers, calcium channel blockers. And in usually older people, it's degeneration is one of the main causes of a complete heart block. And for these patients, we usually put a permanent pacemaker for them. This is an ECG, and we're going to talk about bundle branch blocks at the moment. And I've just got a couple of ECGs to show you. So this is a right bundle branch block. And the way I know this is that we look at the QRS morphologies in V1, and we look at V6 as well. And what we see in V1 is that we have an R prime pattern. It's like bunny ears, where we have a positive deflection R and then another positive deflection. And in V6, we have a deep S wave. And so that's a right bundle branch block. This is another bundle branch block, but this is a left bundle branch block. And what we see here is that we have a deep Q wave. We might have a small positive deflection in V1, but it's usually a very deep Q or a deep S wave, as well as a positive RSR and V6. And so this is a left bundle branch block. A lot of doctors or students, they remember bundle branch blocks with the mnemonic William Marrow. I'm not sure if you all still use it, but that's a good mnemonic. So William is a W wave in V1 and an M wave in V6. That's for a left bundle. And Marrow is the same thing, but for right bundle branch block. Okay. So let's talk about ST elevation. You're gonna want to learn this definition because you're gonna be reciting it for the rest of your life. And an ST elevation is any new ST elevation in 2 leads more than 1 millimeter, except V2 and V3. In the cases of V2 and V3, any male above 40 has to be more than 2 millimeters. Any male less than 40, it's more than 0.25 millimeters. Sorry, those are centimeters, not millimeters. And anything more than 1.5 millimeter, that's the female. You can also assume that any new left bundle branch block is significant, and you should take it seriously. In addition to ST elevation in certain leads, we look for something called reciprocal changes in other parts of the heart. And I'll show you what I mean by that. So reciprocal changes, we use something called the Pales mnemonic. So if you're suspecting a posterior ST elevation MI, you may get an ST depression in the anterior leads. And if you get an ST elevation in the anterior leads, then you may get ST depression inferior. ST elevation inferior causes ST depression in lateral, and so on. When it comes to the lateral ST elevation, it may cause ST depression both in inferior and septal leads. So that's something I'll show you later on as well. This is your map for ECG for the territories of the heart. So as you can see, lead 1, AVL, V5, V6, those are lateral leads. Inferior leads are 2, 3, and AVF. Anterior leads are V3 and V4, and septal leads are V1 and V2. There are posterior leads, but that you do a posterior ECG, and I think that's outside the scope of this session. So I may want to ask for a couple of participants. If anyone wants to participate, does anyone want to contribute and interpret this ECG for me? It's an ST elevation. No one's brave enough.
I don't mind going first.
Okay. So what are you looking at?
So I can see ST elevation specifically in leads V2, 3, 4, and possibly V5 and V6. So I think this is an anterolateral STEMI.
Oh. Okay, excellent. Yeah.
Yeah.
So just like you said, definite ST elevation in V2, 3, and 4. And it's more than 2 millimeters. So that's significant. But also, if we use the Pales mnemonic for reciprocal changes, so if we go back, so we say that there's anterior ST elevation, we assume that there's inferior ST depression as well. It's not always there, but if you see lead 3 here, you see that there may be a slight element of ST depression that's evident. So that further supports your diagnosis that it's an anterior ST elevation MI. Okay, who's next? Yalla. No one wants to participate? Okay, so I'll go through this one. And same thing, we look at the rate rhythm, so it's regular rate, regular rhythm. It may look a little scary, but the most important thing is just to look at your territories. So we said, so we have the lateral territories, we have the inferior territories, anterior and septal. So if we look at the lateral territories, lead 1, we do have ST elevation in lead 1 and AVL. Maybe a little bit in V5. I can't see anything in V6. So this is a lateral STEMI. So by looking also at our reciprocal changes, a lateral ST elevation MI can cause reciprocal changes in inferior leads, as well as septal leads. Okay, and I'll give you a closer look. So that's the ST elevation in lead 1. That's about 2 or 3 millimeters. And these are the reciprocal changes. So I've got reciprocal changes in lead 3 and V1 as well. So V1 is considered a septal area for the ECG. Is anyone brave enough yet? I'm going to have to bring some presents next time. Okay. Yes.
Can I interpret it?
Yes.
So there's ST elevation in leads 2, 3, AVF. So this is inferior MI, and reciprocal changes in AVL, I think. Yeah.
Perfect. Excellent. All right. So, sorry, I didn't catch your name. Who was talking?
Dalal.
Dalal. Thank you, Dalal. So yeah, like Dalal said, ST elevation leads 2, 3 in AVF and reciprocal changes in AVL. Okay, so that's just a closer look. I put some close-up images because I wasn't sure that the quality would be beneficial in Zoom. Listen, for non-STEMI, I didn't include any ECGs. We saw ST depression in the previous ECGs that I showed, but it's also important that if you do have or you assume that you have ST depression in certain leads, it's always important to look for ST elevation elsewhere. It's only when you made sure that there's no ST elevation elsewhere that you consider this, okay, this is a non-STEMI. Okay, let's move on to tachycardia. It's a very broad topic, and especially SVTs, there's many different ECGs to go through, so I only picked a few of them, and we'll go through them one by one. So I'll do this one myself because it's pretty easy, but this is a irregularly irregular ECG. We can see that there are QRS complexes, but definitely I cannot see that there are obvious P waves. You might be seeing these positive deflections here. These are probably T waves, okay? So these are QRSs, these are T, and then followed by QRSs. I can't see a P wave, so this is atrial fibrillation, and it's a pretty straightforward ECG. Who wants to interpret this ECG? Okay. When looking at this ECG, so this is a timeline of a patient. This patient came in with palpitations. He was previously healthy, and he was quite stable. So when we saw him in the emergency room, it's very difficult to figure out what's causing this tachycardia. So after reviewing with the cardiologist, we decided to give him a medicine that blocks the atrioventricular node, and so the QRS beats were slowed down, and then we got that atrial contraction. So this
SVT.
is so you can assume that this is an SVT, and atrial flutter is a cause of an SVT, okay. But it's not the classical like AVNRT, AVRT. This is an SVT, but it's caused by an atrial flutter. So you see that sawtooth pattern showing up after we gave him some medicine to block the AV nodes. So we gave him medicine to block the AV node, and then the QRS is slowed down, and then that sawtooth pattern showed up.
What was he given?
Adenosine.
Adenosine, yeah.
Yeah. So in your SVT, that's part of your ACLS protocol. I'm not sure you guys do ACLS in the UK. I think it's a different type of course. Okay. So it's atrial flutter. This one is more classical SVT, and what we do see here is that this is a regularly regular rhythm, and I'll tell you why now. So what we can see is that there are QRS complexes, and the rate is around 150. You would think there's no P waves. I can't see P waves here. I see a T wave, but there are P waves hidden right after the QRS. And what's happening is that the atrioventricular node is firing, and it's firing on the sinoatrial node retrogradely. So you get that little bump there, that's a P wave. And so usually most SVTs show up like this. You get a very rapid rate, and there's usually a P wave hidden within the QRS. So that, especially in V1, you can see that little bump there, those are P waves. Okay. Maybe here as well in lead 1, you can see a little bump. Those are P waves. Okay, so that's a supraventricular tachycardia. What about this one? Does anyone want to try interpreting this? Okay.
Hyperkalemia?
So let's take it step by step. So tell me about the rate.
The rate is 1, 2, 3. He's tachycardic. I didn't fully calculate it, but I can see several R waves, and the RR interval is
What's
shortened.
the RR interval?
So it is
How many boxes?
2, 3. Yeah, 3, 1, 2, 3. Yeah, 3 boxes and a half.
Yeah.
So,
3.5, yeah.
Yeah.
So 300 divided by 3.5, that's
Yeah.
probably
85.
85.
85 actually, yeah. So
Yeah.
So it's normal.
Okay. So normal rate. Okay.
Yeah.
I'm just gonna. Okay. What about the? We said the rhythm is regular. The rate is normal. What about the PR interval?
Shortened PR interval.
Yes.
Is it? Wait,
Okay.
0 point.
It's very difficult to say, but I would say that this is a short PR interval.
Okay.
All right.
Okay.
So that means that the electricity is going through an abnormal pathway. All right, because the ventricles are being stimulated earlier than usual. Usually what the AVN or the atrioventricular node does is that once it receives it from the sinoatrial node, it pauses for a bit and then it releases the impulse. But when you have an accessory pathway like Wolff-Parkinson-White, okay, what it shows is that it has a very short PR segment. And this upsloping, it's a very slow upslope for the QRS, and that's because it's not going through the regular conducting system. It's going through the ventricles, which is a little slower. So you get that slow upslope.
Okay.
And that's Wolff-Parkinson-White, okay? And this is type of an SVT. So supraventricular tachycardias, there's a broad range of differentials. Sinus tachycardia could be one of them. Multifocal atrial tachycardia, atrial fibrillation, flutter. AVRT, such as Wolff-Parkinson-White, which we just showed, and AVNRT, which was the ECG that I showed before that, with the P waves within the QRS. I'm just going to give you a couple of slides on electrolyte abnormalities. Does anyone want to interpret this ECG? Not Ahmed.
Yeah, I give up.
It's okay. Like we're only here to learn, and like it doesn't matter if you get things wrong. I still get things wrong, and I'm in the CCU.
Hyperkalemia.
Excellent. Who was talking?
Munira.
Munira. Hello, Munira. Okay. So what makes you think that it's hyperkalemia?
Elevated T wave.
Okay. Is there anything else that you want to add?
لا بس أعرف هذا.
Okay, مو مشكلة. Let's interpret this without assuming that it's hyperkalemia. So what's the rate? يلا ميرا, what's the rate? So we said calculate the 5 boxes, yeah? So 300 divided by 5.
Bradycardia.
So 300 divided by 5, that's 60. Yeah, so he's on the lower side, this patient. Okay. So we said that the little bradycardic can we say that this is normal rhythm? What did we say was normal rhythm? We said P waves after QRS and P waves before QRS and QRS after every P. So is this a normal rhythm?
لا not normal.
ليش؟
ما في P wave قبل كل QRS.
Good. Okay. It's not that there aren't P waves, is that you don't see them. Okay, so they're flat. If you look at V1, there's a little P wave there. That's a P wave. Okay. So V1, you can see the P waves. What about the PR? So since you've seen the P wave, what about the PR interval? What do you think about the PR interval?
Short PR interval.
X. Long PR interval.
ترى ما أعرف.
Okay, مو مشكلة. PR interval, if it's more than 5 boxes, it's a long PR. Okay, so there's a long PR interval. Very subtle P waves. You can't even see them anywhere else, but you can see them here. PR interval and then the QRS. What do you think about the QRS? It's a wide QRS. Okay, it's more than 3 squares. And the T waves, you said we have some very tall T waves, but they're also joined to the QRS. So no P wave or flat P wave, PR prolongation, wide QRS, and it's connected to the T. And this guy probably has a very high potassium. These are the changes in hyperkalemia. We said peak T waves, prolongation of the PR segment, loss of the P, prolongation of the QRS complex. I didn't see any ST elevation, but we have something called a sine wave. A sine wave is when the QRS and the T, they join together. If you remember in math, when you have your sine and cosine, so that's your sine wave. And this is very dangerous. Patient can die if they have a potassium of 8. So this is 2 parts, this ECG. We'll take one part and then we'll talk about the other parts. So yalla Mira, that was very good. Does anyone else want to try interpreting this one? يلا شباب قدها يلا.
هذا نفسه في شيء اسمه totality pointers أو شيء كذي يعني.
اي اوكي صح. انت you got the last part right. بس so it's very good. Do you know any causes of torsade de points?
hypercalcemia أو hypo شيء بالكالسيوم.
Okay, hello. So Nira said that يعني the first thing that comes to mind if I see a torsade is I'm looking at electrolyte abnormalities. بس مو hyperkalemia. كلهم hypo. They're all hypo. Hypokalemia, hypomagnesemia, and hypocalcemia. Okay. So you got the second part right. That's torsade. But what's the cause of the torsade? That's usually. So let's take it step by step. So we have P wave, we have a QRS, we have a T, and then we have something else, and then we have a P. So we have actually this is quite a short PR interval. It's a very narrow QRS segment. There may be some ST depression, and there's a U wave as well. Okay, so that's P, QRS, T, U, P. Okay. This is more closely, you can look at it more closely. So that's a P, QRS, T, U, and P. So this patient had hypokalemia. Okay. Yep. Hypokalemia, and then they developed torsade. Okay, it's always important if someone comes in with a torsade, it's the first thing, one of the first things you look at. So a torsade is a polymorphic VT. Polymorphic because it has different morphologies. They look different. It's not like a regular VT. And it's usually caused by QT prolongation. Some cases are congenital. lots of things are drug-induced macrolide antibiotics, macrolide, which are like clarithromycin, erythromycin, fluoroquinolones such as ciprofloxacin and levofloxacin, and then SSRIs, the psychiatric medication, antidepressants, those also cause acuity. And so if you're in your psychiatry rotation, they do ECGs more than cardiologists, I think. Like we said, electrolytes, look at hypokalemia, magnesemia, and calcemia. And anyone with heart disease, they're also prone to developing torsade. Couple of more ECGs left. This is a type of so this is a ventricular tachycardia. The QRSs are wide, okay? So you can't see any other morphology. You can't see your P waves or your T waves. These are probably T waves over here. That double hump, so that's an R, and then that's a T. But VTs on their own, they require a lecture on their own. The most important thing is for you to recognize a VT. If they're stable and unstable, if they're unstable, you shock the patient. If they're stable, there's different other modalities that you can use. And this is ventricular fibrillation. And if you're seeing this on the monitor, your patient is dead, so you have to resuscitate him. You have to make sure that he's awake first. If he's awake and you see this, there's something wrong with the ECG. But if you see this in an unconscious patient, you know for sure that this is a ventricular fibrillation. There's no pattern at all to the electrical activity, and this patient needs to be shocked. Okay. So yeah, I think we're perfect on time. Yeah. Our take-home message is, even I work in the CCU now, and even to this day, I still use rate, rhythm, axis. I'm very religious with the way I see my ECGs. So have a system, and always practice interpretation, even with normal ECGs. Unrelated medical issues, but we still look at their ECGs and we still apply the same system. And you'd be surprised by how many cases we find who have pathologies that we didn't even know about. And if in doubt, always repeat an ECG. You're all going to be doctors soon, and you're going to be in the emergency room or in the ward, and you're going to have patients with chest pain. So you always take a chest pain seriously, because you never know when that chest pain turns out to be real. And if you have a normal ECG and the patient's still symptomatic, always repeat an ECG and always consult your cardiologist. And thank you. That's all. Any questions?
Thank you very much. That was very useful. If everyone can fill in the feedback form I just sent, that would be great. And we'll send you a certificate for attending.
Okay. يعطيك العافية أحمد.
Afik. Is there anything else you wanted to mention, or?
So which year of med school are you guys in?
I think everyone's at different years. I'm in year 4,
Okay.
year 4 out of 5. So yeah.
Yeah, I think ECGs. It's a continuous. It can get much more complex. I think this is a good basic start to just knowing the basics, and then once you get those, there are more lectures to come. Don't worry.
Yeah. Thank you.
Thank you.
Okay, I'll stop the recording now, I guess.